Hello, welcome and kumusta. Thank you for joining me. This is How, your occupational therapist, and welcome to OT Conversations. In this episode, I want us to have a discussion about the whiteboard or the board round, whiteboard meeting, early morning huddle. There's a lot of things that this situation is being called, but technically, it happens every time. It's a briefing, it's a handover, it's happening regularly. And all it is a process for clinicians to have a handover of what needs to be done during the day. Because people have shifts, particularly nurses, doctors. You always come into the ward and you're always going to be surprised as to who's in, what's happening, where do we want to go. Understandably, the notes are in the medical notes or the electronic medical records. It's all there. The things that needed to happen are all in the notes. But the problem is the accessibility of it is very difficult. So you cannot have a good picture of what's going to happen throughout the day. And these board rounds, they're happening interdisciplinary or multidisciplinary, meaning first thing in the morning when nurses come in, they have their handover. And what time would that be? Around 7, half 7, when the night shifts are about to go, they give a handover to the nurses and it gets allocated so the nurses during the day would know what needed to do. Okay? The physiotherapists would be doing the same thing. They first thing in the morning, they'd have a handover, they'd allocate patients to each other, and that's it. It's planning throughout the day. Doctors will have their doctor's handover. Occupational therapists will have their occupational therapists handover. Handover is a regular thing that is happening in every hospital. So that is the first handover of the day. That is the multidisciplinary or just the transdisciplinary or interdisciplinary. There we go. A handover. And it is just sharing out the workload at the end of the day. The next thing that's been happening is that there is an allocated time throughout the day or in the morning, particularly, where all of these team goes and does a handover. So you sit down together, and I know for a fact, and I've studied this many years ago, I don't think it was just worth publishing, and I'm sure you guys know it as well. If the handover was done standing up, you get to do it at a faster pace, around 15 minutes for an entire ward, as compared to once people are sitting down. So you do a handover. Back in the days, there's just a handover. Everybody's got their paper, everybody's writing things down. Another day comes, you do the same thing again. And then sometime around, 2008, 9 or 10, this whiteboard meeting. It's a whiteboard. So people gather. Around the whiteboard. And why is that? Because at the whiteboard, that is the most urgent or immediate access to whoever is in the ward. I have yet found a hospital where there's a whiteboard where the names are not updated. So whoever is in, whoever is out, whoever is going, it will be in the whiteboard. How many admissions are we expecting? How many beds are empty? It's there, so people gather around the whiteboard. And the objective for the whiteboard meeting is pretty much the same as how it would be when clinicians are doing a handover within their own discipline. What do I mean by this? It just meant that we're planning the day. Which one is urgent? Which ones has issue? Which therapist can look after it, or what needs to be done? That's all there is, guys. It's all about planning the day. It is not a meeting of another handover of what's the case, what's the scenario, what needs to be done. If you want a copy of those handover sheets, just grab the handover paper that's being dished out every morning, every time, every ward. There is a printout of the patient list with the handover notes. See, we don't need to hear that in a whiteboard. All we're wanting to know in a whiteboard meeting is the name of the patient. Here is the patient. They're actively getting medical intervention, or they're done from a medical perspective. They're medically fit, and the EDD, therefore, can be set at this date of time. And if this is the EDD, or the expected date of time, do we need the MDT or any individual MDT members to look at this case? So those are the questions that we needed to ask. Here is a patient, Mr. Smith. Doctors are happy to discharge medically because from a medical perspective, they're happy. Do we have any concerns? Do we have social concerns? If we have social concerns, right, occupational therapist, can you have a look? And social worker, can you have a look? Do we have mobility concerns still? It's that. So there is no pressure for us to actually push for the person to go home if from within our individual profession and our individual professional call, the patient is not safe to go home. All we're saying, all we're highlighting in a whiteboard is the name of the patient. When are the doctors happy? Because the medical clearance or medical fitness is the marker for when we can start doing the discharge planning. That is not to say that we don't get to see patients before the patient gets medically or after all the medical fitness. We can see patients even before they are recovering. So they're not medically fit, they're recovering, we see them. You don't wait for medical clearance before we start to see them. Yeah? And it's this concept of seeing the patient late after the day or after medical clearance. It is this concept which was why the discharge to assess concept was formulated. The doctors and of other MDT members, perhaps OTs, coming in to say, oh, we haven't assessed patients because they're not yet medically fit. And then once they're medically fit and they're standing and walking, going to the toilet and all the other things, the doctors would just say, you know what? This person does not need to be in the hospital anymore. Discharge them home, and then you assess at home. You do your job outside this place, outside the hospital. So that's discharge to assess. In a whiteboard meeting, who should be there? A ward coordinator, which is usually an allocated coordinator in a lot of hospitals, and a nurse coordinator. And every time there is a nurse coordinator in the ward. Sometimes it is the ward sister, sometimes they have a designated nurse coordinator, and these are the hub of information and communication, particularly when it comes to what's happening with the patient. What are the plans? What are the discharge plans? Do they need transport? Are there social services? The ward coordinators are there consistently every day. They don't have shifts. It's always Monday to Friday. They usually have people on the weekend too. And that is the hub of information and communication, because what happens are nurses have their individual base, their individual units, and you'll have to find the nurse. And that's not efficient. So just have a single point of coordination, and that would be it. They would be the people, the ward coordinators. So who's there? Ward coordinator or the nurse coordinator. That's that, okay? There has to be a way for the doctors to inform the team that the patients are medically fit. Either informing the ward coordinators, either writing it down on the handover sheet, or either updating the whiteboard themselves. That's why in the whiteboard, there is this medically fit for discharge section or medically optimized for discharge section, where all the doctors need to do is write down the date that they are happy or that they anticipate that the patient will be medically optimal. Why are these things beneficial for therapists? It's because occupational therapists can plan their day and they can prioritize based on the expected date of discharge, based on the medical optimization. Why are we dependent on that? Because if we have to request for short-term and reablement care, short-term and reablement care will not be instigated and social services will not even look at it if the person is not identified to be medically fit or medically optimized. So we need the doctor or a representative of the doctor, which can be a nurse. So we need a ward coordinator or a nurse coordinator, because sometimes the nurse coordinator is the hub for the doctor. The doctors are the ones that are informing the nurse coordinator as to who's going to be medically fit or not. And that's it. If you use the board, you don't even necessarily have to sit down and plan if you update the information that you needed. Imagine coming into the board, and I've done locuming for a long time, right? 21 hospitals in the United Kingdom. And I am so used to not knowing who the patients are. You will see there is a list of the patient. And then these patients will have an EDD, expected date of discharge. If you update your section and if you've seen, you've assessed, as occupational therapist, you will have to set the conditions for discharge. And what will be the conditions usually? The conditions for discharging a patient would be 1, medical clearance. That's 1. You can set the condition that the patient needed to be discharged by physio in terms of their mobility, in terms of their stairs, or any other things that physio needed to be responsible for. Say, for example, chest or oxygen, things like that. You need the patient to be functionally safe. And what are the reasons and what are the things that a patient needed to be safe at? Their functional mobility, physio clearance, okay? Their toilet hygiene, they should be able to do that, okay? So those are the things. So physio clearance, medical clearance, all right? And the other thing is occupational therapists will have to look at the scenario and see whether the person is going to be safe or not when they go home, or do they need another form of short-term help or assistance. If the board is updated, then people can save even 15 minutes of time. Sometimes, from experience, whiteboards happening for half an hour every day, talking about the same things over and over. People go and then you talk about the same things over and over. It's a groundhog day. And it is so inefficient. It needs to happen all at the same time for all of the hospitals and all of the unit. And what do I mean by that? So if there is one ward, it happens from 8:15 to 8:30 would be ideal, because most of the interdisciplinary team are already in by 8 o'clock. So from 8:15 to 8:30, all at the same time, from one ward to another. You don't have to have a procession going from one ward, then followed by the other, followed by the other. You don't need to do that. To get the expected date of discharge, you can train people to put those dates. We can train the doctors to put medical optimization date. If they're medically optimized and there is still some outstanding issue, it's possibly one trigger that will get a person into a community bed or community assessment bed or optimization bed somewhere or a rehab facility. Yeah. So there's medical optimization. The other one is properly medically fit, because the main star why people go into a hospital is because they really need medical attention. So if they don't need medical attention anymore, people need to go. But having said that, it's not all about doctors. It's not all about medicine. There are other problems, on which case the MDT comes in, multidisciplinary team comes in, because there are functional problems. They don't recover as quick. They become frail. They deteriorate functionally, and we need to act on that. Very simple, guys. Whiteboard is all about a simple planning of what or how the day is going to be. If you do not know what the situation is, it's a good time for a therapist to find out which patients he needed to prioritize throughout the day. So if you don't know what the plan is for that patient and you're in the whiteboard, that's okay. All you need to do as an OT is to say, yeah, noted, let me get back at that, let me have a look at it. Then you have time to look into somebody's notes, and there you go. Then you can identify what the plan is, and then you update the ward coordinator. Very simple, very simple. It shouldn't be stressful, guys. It shouldn't be stressful. Just remember, take advantage, make use of this whiteboard. It's a tool, okay? How do you update it? What is the best way on how to update these things? Sometimes people put a date on it, okay? Others use a type of traffic light system. And this is very good. It's even better when it comes to seeing the state of the unit or of the ward. And how does it work? So if a person is not known, so there is nothing, it means we need to know, isn't it? Any MDT member. So all individual teams, so there's physio, there's OT, there's social worker, right? So one color is assigned for not applicable or not suitable, perhaps blue. So say a social worker comes in and they see, oh, this person is fine. The nurse can just put, oh, blue, this is not required. So at a glance, social worker can just have a look at it and say, that's not suitable. Somebody made that call. You trust the team. That's fine. If a person is red, for example, it meant that the person needed to be seen and yet have not yet been seen. So no assessment has taken place yet. So that's a red. That would say that person I need to at least screen, or at least I need to know what's been happening. So that's a red. Okay. And as soon as you've seen, as soon as you know what the plan or what the scenario is, then change it into the next stage, which would be amber, meaning you are aware of the patient, you are actively working on the patient, but you haven't discharged them yet. So that is an amber. And then if you are happy and that you have discharged from your individual profession, then you can simply click it into green. Straightforward, isn't it? There we go. So you just use it. It's a tool, guys, that is there, that is always available. You don't want to make it difficult and complicated. We're just here to help. We're here to help each other. We are working in the same area and we have one mutual goal, and that is to help our patients. That is to help our NHS. I hope you learned a little something from this very short talk. Just talk about it, think about it, and have a discussion amongst yourselves. See how you can make your practice better. Until next time, guys. Bye.